posterior cortical atrophy. I spent 6 months at UCSF as a fellow in the Global Brain Health Institute, and I think that it's really important to educate people about PCA, optometrists, ophthalmologists, neurologists, so that people aren't in the dark about this disease and they don't go for years without a proper diagnosis, because these conditions happen in the prime of adult life. And so that's my goal. And the way this is going to work through Zoom is that if you don't, we take privacy very seriously. If you don't want your name up here, or if you don't want your name to be turn off your video and your audio in terms of when we ask questions, because this is going to be taped. And if you don't mind, that's perfectly great also. And because this will be put onto our Facebook page, and the Facebook page, the Posterior Cortical Atrophy International Group page. That said, I think that's the only housekeeping, Michael. Gil?
Okay, and I'll just say yes, I have hit the record button, so I am recording this. And
wonderful.
I've muted just about everybody except you and Gil, so you're on, Gil. Thank you.
Okay, thanks everyone for participating. Let me see if I can share my screen. Can everyone see? Can everyone see the Golden Gate Bridge in the title slide?
Yes, but you probably can't hear us.
Oh, because you're muted. Okay.
They're muted. I'll give you the thumbs up, and a few other people did too, so that's good. Thank you.
Okay, great. So I'm a neurologist at UCSF. As Jamie said, I've been working with posterior cortical atrophy, as well as other atypical and young age of onset forms of Alzheimer's disease. And so really, this is a brief talk. I guess it's the first talk for the group. So I thought I would really focus on an overview of the disease. I'm going to discuss the history of PCA in terms of the neurologic literature. When was the syndrome first described and by who? I'm going to spend a lot of time talking about, or trying to help you understand the disease. So which brain areas are affected? How does that lead to the specific symptoms? I think a very common question is, how is PCA related to Alzheimer's disease? Are they the same? Are they different? If so, how? I'll address that question. Another very important, obvious question is, why do people get PCA? So I'll try to explain what we know currently about genetic and non-genetic risk factors for the disease. Then I'll put you in the neurologist seat. I'll tell you about our clinical approach to evaluating patients in whom we suspect PCA, how we make the diagnosis, and how we use increasingly sophisticated brain imaging to try to confirm our clinical suspicion and provide people with an accurate diagnosis. And I'll end with a few words about treatment, and then we'll have a Q&A. So posterior cortical atrophy is sometimes referred to as Benson syndrome. And the reason is that this disorder was first described by Frank Benson, who you see here. Dr. Benson, it was pronounced, or an eminent behavioral neurologist who practiced at UCLA. He's actually my academic grandfather. He trained my mentor, Bruce Miller. And so in academia, we have lineages and pedigrees. So he's my grandfather in academic terms, though I never had the opportunity to meet him. In 1988, Dr. Benson described 5 patients whom he had evaluated at UCSF who presented with a progressive disorder of what he called higher order visual function. I'll explain what that means in a minute. And notably, other cognitive processes like their memory, their insight and judgment were really preserved in the early course of the disease. And he named the syndrome posterior cortical atrophy because brain imaging, CAT scans or MRIs, which were just in their infancy at that time, revealed a loss of tissue or atrophy in the back areas of the brain, or posterior is the medical term, areas of the brain that are important for visual processing. And At that time, Dr. Benson didn't know what caused PCA, but he astutely hypothesized or speculated that the disease might be due to an atypical form of Alzheimer's disease. And about 15 years later, he was proved correct on that point. So to understand PCA, you really have to understand the wiring in the brain that allows us to process visual information. So this is your brief neurology primer for the talk. This diagram looks complicated, but the basic idea is that visual information is transmitted from our retina, the back of our eye, through a variety of relay stations in the brain, eventually into this part of the brain that I'm showing here with my cursor called the occipital cortex, which is the primary area that begins to process visual information. And the processing becomes increasingly complex. So first, the brain determines things like contrasts and basic shapes and colors, and eventually adds on layers like contours and 3 dimensions. And from there, the brain starts to do what we call higher order visual processing in terms of putting the visual scene together and relating it to other information. And this really goes in parallel through 2 brain circuits. So from the occipital cortex, information goes up in the brain into an area called the parietal cortex. And this visual circuit, also called the dorsal stream, helps us understand spatial relationships, helps us judge where things are, how different elements in the visual scene are related to each other, what are the relationships between them. And then in parallel, information goes into an area of the brain called the temporal cortex, shown down here. And this is called the ventral visual stream. This helps us identify what it is that we're seeing. So helps us identify objects. If I'm looking at a knife, this helps me identify that this is in fact a knife, or helps us identify faces, helps us relate the visual information to other knowledge that we have about the world. And so this is the very basics of how visual information is processed in the brain. And what happens in PCA is that this processing goes awry. And so this leads to clinical symptoms that many of you are familiar with. And they really have to do with dysfunction of either primary visual processing or these higher order visual processing processes. So people have trouble judging spatial relationships, where things are in relation to other things, orienting their bodies in space. People have trouble locating items, opening the fridge and looking for that leftover Chinese food and just not being able to find it even though it's right there in front of them. People might have trouble identifying objects that they see or faces that they see if they have disruption of this ventral visual stream, the what stream. People have trouble putting individual elements of a visual scene together to see the big picture. So many of you might be familiar with the parable about the blind men who were trying to feel the elephant, and each person was feeling a different part. One person was feeling the tail, and another the trunk, and the other the leg, but they couldn't put together the whole object as an elephant. And that really can occur in PCA. People might focus on specific elements in the room, but not be able to see the big picture. When there are problems with primary visual processing, people develop what we call the visual field cut, or trouble seeing things in their peripheral vision, have trouble identifying obstacles or boundaries, and so they might bump into things. And I've highlighted in red some of the very early symptoms that people might have in PCA: trouble with reading and loss of confidence driving. I think these are the 2 most common first symptoms that I hear about in PCA and that make me worry about the disease. But of course, the disease is also affecting other brain areas that are not directly involved with visual processing, and so people have non-visual symptoms as well. People might have trouble with calculations or doing mental math. People have trouble finding the right words, trouble writing. People might have a lot of trouble using devices, the remote control, appliances, a mobile phone, that's beyond just the visual challenges with operating these devices. And people might have trouble planning more complicated movements. A lot of people complain of imbalance or dizziness. This has to do with the fact that visual information is really critical to our equilibrium, to our vestibular system, to our sense of balance. And so when you lose that visual input, that creates this imbalance or dizziness. Folks might have trouble confusing left and right. A lot of people have trouble dressing, really orienting their clothes correctly in space in order to put them on correctly. So this is not a comprehensive list, but it's a list of some of the most common symptoms of PCA. And really, it's the constellation of these symptoms that allow the neurologist or the doctor to make the diagnosis. Now, we don't really know how common PCA is in the general population. We do know that on average, it tends to present at a relatively young age compared to the typical age of onset of Alzheimer's disease. So PCA specifically affects people in their 50s and 60s, though it can begin even at a younger age and sometimes may present in older folks. It does seem in most studies that females are at higher risk than males for getting this particular disease. And again, while we don't know how many people are affected, there are some studies that suggest that PCA makes up anywhere between 5 to 20% of all patients who have Alzheimer's disease that are seen in academic centers or real specialty clinics. So at UCSF, for example, in our Memory and Aging Center, we estimate that about 13% of all patients with Alzheimer's that we see have PCA. Another thing that's really uncertain is the rate of progression. When when doctors tell you that we don't know how this is going to progress in the next year, 2 years, it's not a cop-out. It really is highly variable between people. What we do know is that this is a progressive disease. The visual problems do progress and become more severe over time, and at the end stage really can lead to functional blindness, to an inability to really use vision effectively for function. And then over time, most patients will also develop problems with other aspects of cognition, such as memory, language function, judgment, problem-solving abilities, though in some folks, a lot of this can be preserved for many years as the disease is primarily focused in the visual system and doesn't spread into these other brain areas until years later. In other folks, these areas might be involved earlier on. So PCA is really a constellation of symptoms. It's a pattern that we recognize as neurologists. Alzheimer's disease, in contrast, refers to a specific biology or to molecular changes that are going on in the brain, to the deposition of two toxic proteins in the brain called amyloid plaques and tau tangles. And so what you see on this slide is a brain specimen after someone has passed away, demonstrating these protein deposits. Here in the blue circle, you see amyloid plaques. They sort of look like a flower here with a dense core, and they deposit in the extracellular space or between brain cells. And what you see here circled in red are neurofibrillary tangles or tau tangles that are depositing inside neurons or brain cells. And so it's really the combination of plaques and tangles that allows a pathologist to make a postmortem diagnosis of Alzheimer's disease. And this is the biological definition of Alzheimer's. And so it turns out that 80% of patients who presented with symptoms of PCA during life and then had a brain autopsy, about 80% of folks are found to have the plaques and tangles of Alzheimer's disease. And that is why PCA is sometimes referred to as the visual variant of Alzheimer's disease. It's very strongly linked to this biology of plaques and tangles. Now, interestingly, the distribution of the plaques and particularly the tangles is different in PCA in that we see more of this pathology in visual areas and relatively less pathology in memory regions and other brain areas, whereas in people who have a more typical clinical form of Alzheimer's disease that presents with memory loss, the opposite is true. We see more pathology in memory areas, and actually visual areas don't become involved until later on in the disease. Now, about 20% or fewer of people who have the PCA symptoms and come to autopsy are actually found to have a different brain disease. So it's not Alzheimer's, but it's another disease. Some of you may have heard of diffuse Lewy body disease. This is probably the second most common cause of PCA. This is a disease that's closely related to Parkinson's disease. Corticobasal degeneration is another neurologic condition, a relatively rare one that can present with the symptoms of PCA. And then there are a number of other symptoms. And so it's not a one-to-one correspondence. The PCA syndrome is usually, but not always, caused by the plaques and tangles of Alzheimer's disease. So the clinical diagnosis by the neurologist or the doctor is really based on getting a good history and performing a neurologic exam. It's critical to establish that the symptoms began gradually and progressed slowly. If they began very suddenly overnight or evolving over a couple of days, it's probably not PCA. It's probably some other process, a stroke or a mass or something else going on in the brain that's affecting visual function. So this disease, as many of you I'm sure have experienced, begins very slowly and insidiously and progresses gradually. It's really important early on to rule out a primary eye disease that could be treated. Really the diagnosis of PCA, you can't make the diagnosis until you rule out that there's a primary problem with the eye that's compromising visual function. Of course, we know there's a high rate of misdiagnosis as well, and that the symptoms of PCA are initially attributed by an ophthalmologist to cataracts or glaucoma, and then these things are treated or the cataracts removed and the problems persist, and then finally someone figures out that it's a brain problem, not an eye problem. The neurologist or doctor often refers folks for neuropsychological testing, where we actually do former paper and pencil tests of visual function, memory function. Hey, I think we're hearing some background noise there, sorry. So we're testing spatial function, memory function, language, and executive functioning to try to determine the involvement of these different aspects of cognition. And then we order brain imaging. The minimum, everyone who is suspected of having PCA should have some kind of brain imaging, typically a CAT scan or an MRI scan. And this is really done for two reasons. One is to rule out strokes or tumors or other things that can affect visual areas that might present with the symptoms of PCA. But the other reason is really to look for that loss of tissue that is usually seen in the disease. Another common brain imaging technique that's used is a PET scan with a compound called fluorodeoxyglucose or FDG. This is a compound that looks at metabolic activity in the brain and is able to determine when someone is just lying in the scanner at rest, which brain areas are more metabolically active, which ones are using more or less glucose. And it turns out that brain areas that are affected by a process like PCA become less metabolically active, the brain is less active, and that pattern can be detected on the scan. And I'll show you some images to demonstrate that in the next few slides. A recent advance just in the last 10 years or so is that we can actually detect in living people some markers that directly tell us about the presence of plaques and tangles. And this can be done either by examining spinal fluid and measuring levels of the amyloid and tau proteins in the spinal fluid, or using PET scans that are now looking for amyloid plaques. And there are new PET scans that can detect the tau tangles that are currently in development, but these are not yet available clinically outside of the research setting. And so here's an example of one test that we do for visuospatial function. Here we have patients copy different designs. This intersecting pentagon design may be familiar to many of you. This is part of a standard exam called the mini mental state exam. So here you see the original design, and here you see a copy of the patient who suffers from PCA, and you can see that the copy is incomplete, that there's trouble seeing certain aspects of the image or accurately depicting the spatial relationships, for example, between the pentagons. Here's another figure that we have in our battery at UCSF that we ask patients to copy. This is actually called the Benson figure after Frank Benson, which is why I show it. And here's another copy by the same patient with PCA. And you can see, again, a lot of trouble seeing the big picture, understanding how these different elements are related to each other spatially. Here on the bottom, you see another couple of examples of tests that we do for visual function. So this is a dot location task where we ask patients to identify the location of this dot as corresponding to one of these numbers. You can see it's not so easy. The correct answer is 2 for those of you who are scoring at home. So this is a test of that dorsal visual stream, or the where stream, that helps us identify where things are in space. Here's a face recognition task where we ask people to match this face and say which one of these 4 faces best matches this one. This is a test of the ventral or the what stream, again, looking at people's ability to identify facial features. Here's the correct answer. Here's an example of an MRI scan which demonstrates the key finding in PCA, which is loss of brain tissue in back or posterior areas of the brain. And so the brain is a convoluted structure. It's formed by gyri and sulci, or peaks and valleys in the surface of the brain. And what you see here is that in the front of the brain, you can see the brain tissue is very densely packed. But as you look at the back of the brain, demonstrated by my cursor here, you see more space between the peaks or the gyri and deeper valleys or sulci. So there's been loss of tissue in these brain areas. And I think you can appreciate the difference between the front and the back, even if you're not experienced at looking at these scans. Here's an example of a metabolism or an FDG PET scan, again, looking at brain activity in different areas. And here, red indicates normal brain metabolism, normal activity, and you can see that you see a lot of red here in the front of the brain, but as you go to the back of the brain, you're starting to see more yellow, green, or even blue. This represents areas in the back of the brain that are less metabolically active, less active in the setting of PCA. And so these are just some of the imaging tests that we do to confirm the diagnosis. Now, we think in general, Alzheimer's disease and PCA begin years before people even have the earliest symptoms in terms of some of the protein deposits and loss of tissue that we see in the disease. And this is a study from a person who joined our study at UCSF as a normal control. She enrolled in a normal study of aging, but 4 years into the study, she developed PCA. And what we found when we examined her brain MRI is that even before she had any symptoms or any problems with our visual tests, there was already loss of tissue or brain atrophy shown here in red in the back areas of the brain, suggesting PCA was brewing before any symptoms had yet developed. And now you can see the red areas or the atrophy later on in the course, and you can see that this is progressing. And here's year 4 where she develops the full PCA syndrome. You can see loss of brain tissue again in these back or visual areas of the brain. And so we think the atrophy begins probably years before even the earliest clinical symptoms of the disease. Now, more recently, there have been advances in technology that allow us to identify plaques and tangles, or amyloid and tau, associated with PCA. And so these are PET scans again, but now red here indicates the presence of amyloid plaque deposits in the brain, those flower-looking like structures that I showed you. And this PET scan here, red shows the deposition of neurofibrillary tangles, or tau tangles. And so you can see that the amyloid plaques in this patient who has PCA are really distributed throughout the brain in the back, but also in the front areas of the brain, whereas the tau tangles, again in red here, are mainly focused in the back areas of the brain, in the visual areas. And now I'm going to add that metabolism scan and the MRI scan, and you can see that really where the tangles are is where there's brain dysfunction. So you can see a lot of red, a lot of tangles here, and less activity here. Similarly here, you can see red more on the right side of the image than the left, and you can see that there's less brain activity on the right side compared to the left. So it's really where the tangles are that determine brain areas that are showing dysfunction and leading to clinical symptoms. And so now we really have a very full picture of a lot of the processes that are going on in the brain and PCA during life: deposition of plaques and tangles, loss of brain activity, and loss of brain structure. And we think that these imaging tests are really going to be critical to help us develop drugs and determine if they're working. A very common question is this a genetic disorder? What are the chances that my children or grandchildren might have PCA? What we've seen is that patients typically don't have a strong family history when they present with PCA, and PCA is not associated really with gene mutations that cause familial forms of Alzheimer's disease that are transmitted from one generation to the next very commonly. A recent study that we did in collaboration with an international consortium of 11 centers across the country allowed us to analyze DNA from over 300 patients who had PCA. And what we found is that there's a relatively weak association with what we consider typical risk genes for Alzheimer's disease. Like some of you may have heard of the ApoE4 gene as a risk gene for typical Alzheimer's disease. This gene is only weakly associated with PCA. And really interestingly, and I think importantly in terms of thinking about therapies, we identified 3 candidate genes that may specifically promote risk of PCA itself. And these are genes that were associated with development and cell signaling in the retina, in the eye, and also in visual pathways. So this is really our first clue that there may be specific genes involved in the visual system that might put people at risk for getting PCA. As Jamie alluded to, it also may be that people who develop PCA have an increased susceptibility or developmental susceptibility to the disease. And this is work from Zach Miller in our group, who looked at the prevalence of what we call nonverbal learning disability. So trouble with spatial skills, geometry, spatial reasoning, reading maps, sense of direction, and also problems with numeracy that people experience throughout their life. And what he found is that the prevalence of these disorders in PCA was on the order of 12%, which is about twice the rate in the normal population, and also much higher than the rate that was seen in people who had a typical form of Alzheimer's disease with memory loss. So here we have a clue that people might be born with a relative vulnerability or susceptibility of these visual circuits, and that this might be a risk factor for developing PCA later in life. In terms of treatment, in terms of drugs, really our first-line therapy are the drugs that we use to treat Alzheimer's disease. As you know, these drugs are not cure, but what they do is they address some chemical changes that occur in the brain as a result of the plaques and tangles of Alzheimer's disease, and these provide some symptomatic benefit or at least slow the rate of decline. And so the first-line therapies that we use are drugs called cholinesterase inhibitors. These are drugs like Aricept or Razodine or Exelon that promote a brain chemical called acetylcholine that is lost early in Alzheimer's disease. These drugs restore some of the function of that chemical or neurotransmitter. Another drug that is used in more advanced disease stages is a drug called memantine or Namenda. If folks have depression, of course, antidepressants can be helpful to address that aspect of the disease. Really important, I think, to think creatively about resources that are available for the blind and partially sighted to see if these can help people with PCA. So audiobooks, talking watches, mobile phones that have simplified displays, voice recognition software that allows people to activate software with their voice, not by typing, culinary aids, these are all available. Making some changes in the home or in the environment can help people function better. So reducing clutter can help people locate things more clearly. Increasing ambient light in the house can often help. Making clear contrast, say where a stairway is about to begin, might help people identify these obstacles more easily. And then there are rehabilitation and supportive services like occupational and physical therapy that allow people to help with their balance, to maximize their function given some of the visual challenges. Support groups can be very helpful, and the Alzheimer's Association is always a very good resource to help with questions and practical advice. And so I'll end the lecture part of this talk here. I'll thank all the people in my lab and collaborators who have helped put together some of the data that I've shown you today and the funding sources. So thanks a lot.
I hope that was informative, and right now we are going to take some questions, and you can go down to the bottom where you see the chat. You could type in your question, and then I will deliver that question to Dr. Rabinovici.
And Gil, there was a question from Sonia Israel. I think I texted that to you. I'll just read it. What can be done to get PCA patients into clinical trials, such as TGE Biogen 1 or some of the new tau trials?
Yeah, this is really a challenge. And so a lot of times patients with PCA are excluded from clinical trials for 2 reasons. One is they may be too young. Often clinical trials have an age restriction and a lower limit of a younger age, and people might be too young. And the other thing is a lot of trials, including the Biogen trial that was mentioned, enroll people based on their memory performance. And of course, people with PCA might perform perfectly well or on memory tests. And so a lot of the focus in current trials has been on typical older memory predominant Alzheimer's disease. And this is a real challenge. Now, there are some trials, especially earlier phase trials, that do allow patients with PCA to enroll. But we're really, we see this as a huge need for patients. And what we are trying to do in collaboration with Brad Dickerson, who Jamie mentioned, Liana Postolova, who's at Indiana University, is we are trying to develop a network of sites that will specifically enroll patients with PCA and other young or atypical forms of Alzheimer's disease who are interested in being engaged in research. And we hope that this network will provide a platform then for clinical trials that are specifically recruiting people who have PCA or other atypical forms of Alzheimer's. And so actually, right before giving this webinar, I'm jet lagged. I just got back from Europe a couple of days ago, so I was up at 3:30, and what I did early this morning was work on that grant application. So we're working very hard to try to develop a network that will enable folks with PCA to participate in trials, but we're not quite there yet. I guess my practical advice for right now is to check clinicaltrials.gov, which is a very good resource. Search for PCA to see if there are any specific trials looking at PCA. And then for the Alzheimer's trials, you can search to see what the age restrictions are, and you can consult with the doctors taking care of you whether you might be eligible for a trial. I do believe that some of the trials that we have, some of the earlier phase trials that we have at UCSF, for example, are enrolling people with PCA, but that really varies trial by trial and site by site.
Robin, who can't talk to us, said that she was disappointed that she couldn't get a research institution to conduct an autopsy on her husband who just died in May. Gil, can you offer any suggestions about donations to figure out more about this disease?
Yeah, obviously brain donation is the ultimate gift and very much needed and to advance our understanding of the disease. A lot of sites enroll patients who have been followed in other research projects in brain donation, and people can have a brain autopsy done if their loved one participated in previous research. If someone was not involved in a research project or in a university setting, it's a little bit harder to get a brain autopsy done. But there are some programs that perform brain donation and autopsies in people who have not been followed previously in research. And I don't have specific information about that at the tip of my tongue, but I can talk to our autopsy coordinators here at UCSF, and we can try to provide some information on the website about that after we're done with this webinar.
Great. Are there any more questions?
There's a question from David Bender saying, how do you know if the Alzheimer's medicine is providing any benefit?
That's a great question, and it's a really difficult question to answer because the Alzheimer's medications don't typically improve people's symptoms. People don't feel better. And over time, we know that they don't prevent the symptoms from getting worse. But what we do know from many studies in typical Alzheimer's disease is that the rate at which people progress is somewhat slower in people who are on these drugs than people who take placebo. Now, I have to say as a caveat that these trials were done in typical memory predominant Alzheimer's. There are very few trials that have looked at the effectiveness of these medications in PCA specifically. And I doubt, honestly, that we really will have that kind of trial for a variety of reasons. But I think that the medications are very safe. They're generally well tolerated. I think there's a good biological reason to think that they might help people with PCA, just as they help people with typical memory predominant Alzheimer's disease. And so my practice is to use them and continue them through the course of the disease unless people have side effects or are unable to tolerate them for other reasons. But that is really based on the idea that they are probably helping and likely not hurting. And we need to do better, obviously, in terms of therapies.
Michael, any other questions?
Okay, so there's one more from Jennifer saying, MD, I think. Doctor says, not important to put a name to it and treat like AD. We wanted to see a PCA specialist. Any thoughts on that, Gil?
Yeah, no, I think it is very important to give a specific name to understand what the syndrome is, because that helps folks, plan, understand what's going on, and plan for what is likely to happen in the future. So if I implied that in any way, I'm sorry. I do think it's important to, to put a label on it. I think it's very helpful often to patients and families to understand specifically what's going on with their loved one and not use generic terms. That said, I'm hopeful that the drugs that are being developed for Alzheimer's disease to stop the spread of plaques and tangles will also work in PCA, because even though these plaques and tangles are in different brain areas, it's still, we think, a similar biology that's leading to their spread. And so I am hopeful that ultimately we will be able to treat PCA with effective drugs that are being developed for Alzheimer's disease. In terms of seeing a specialist, I think Jamie can provide some specific names of sites throughout the country. Certainly, we're happy to see anyone at UCSF, and we have seen referrals from around the country and the world. There are other centers on the East Coast, Massachusetts General, the Mayo Clinic in the Midwest, University of Colorado. There are a number of centers that are specifically engaged in PCA research projects and clinical care, and can provide a super expert opinion on the disease.
Gil, I have a question. I noticed that on the international PCA site, a lot of people are talking about staging. My loved one is in this stage, that stage. Could you talk about staging?
Yeah, we talk about progression of the disease and disease staging. A lot of the scales that are used in research or in clinical trials were developed in typical Alzheimer's disease, and so they reflect the degree of memory impairment, and they don't work that well for PCA. But some of the other factors that we use for disease staging are as relevant for PCA as they are for other forms of Alzheimer's. And so we talk about how whether people are independent in their functioning or whether they need help to perform some of their day-to-day activities. And then, how much help do they need in order to perform, daily tasks? And, people might have trouble with these tasks because they're forgetful, but they may also have trouble with tasks because their vision is failing. And so those are some of the parameters that we use for staging.
Wonderful, thank you. Michael, any other questions before we close out?
Well, there's one more. Have the genes that have been found in PCA been identified or not yet? For you, Gil.
Yes. So that first study that we did identified 3 new genes that were specifically linked to PCA. Doing genetic studies is pretty tricky, though, and so we'll have to replicate those findings to see how robust they are in a different set of patients. But I think these new genes might provide important clues that will help us understand why people might be at risk for PCA and what targets might be available for therapies that are linked to these genes. So we're still in early days, and this is another reason why having a multi-site network in the US and across the world is really important. You really need relatively large numbers of patients to do some of these genetic studies. And so if we have a network of patients who are engaged in PCA research, then we can look at the genes with much more power than we can when we're just looking at a couple of hundred samples. That may seem like a big number, and it is a big number for PCA, but it's still a relatively small number for genetic studies, where often you need tens of thousands of samples to really get robust results.
One more comment from Robin Martin. Since we can write obits for our newspapers, I wrote that Ray died of posterior cortical atrophy, a rare form of dementia. Should I have said a rare form of Alzheimer's disease? I want people to learn more about this disease.
Yeah, I mean, again, posterior cortical atrophy is often, not always, but very often due to Alzheimer's disease. And so that would be a more specific way of saying it. I do think that things that we're learning about Alzheimer's are going to very likely relate to PCA, especially as regards to drug development. But I also think that PCA is a unique disease that needs to be studied specifically so that we can really understand the similarities and the differences between PCA and the more typical forms of Alzheimer's disease.
Wonderful, thank you. And we also have one other comment that Dr. Crutch at University College in London and his group has a PCA staging document. And I think that Gil is one of the collaborating authors on a study on the new guidelines that came out this year. And it's a little technical going, but I think that we could put it up on the site to allow people to read that.
Okay, there are no more questions on the chat. I'm going to unmute everybody. If there's anybody that wanted to ask a question but couldn't do it in the chat, I'm going to unmute everybody, but this could be chaotic. So hold on, let's see what happens.
Oh, it's hard to sit here and we run it down.
Oh yeah, well it was about, I don't know if you saw in the news last night, but they showed the fire.
No, let's not do that. I think I just heard 20 conversations at the same time. So I don't think that's going to work. Hang on, let me unmute you, Jamie.
Thank you guys so much for joining us today. We will make this available on the PCA site, and I thank you all for your interest in spreading the word and learning more about this disease. Gil, thank you so much. That was amazing.
All right, thank you. And also say there were some other comments from Sonia that I will pass on to Gil and Jamie to make sure that they get that. And did you want to say something, Sonia? There you are.
Can you hear me? Am I
Yes.
unmuted? Yeah, no, that was great, Gil. Thank you. I've been studying sleep in Alzheimer's for about 40 years, and unfortunately, I'm also a caregiver now. And I just think we need to do so much more to try to get our patients into these clinical trials. And the issue often is that the visual component is lowering their scores. So even though some of the memory problems may be there, if it wasn't a visual part, they would reach the lower cutoff for these trials. So anything I can do to help you, whether you want to do a investigator-initiated trial to Biogen or one of the other ones, or on your grant. I have 40 years of grant writing experience, well-funded. I'm happy to help.
Well, thanks for that. I think that's a great point. We see a lot of times misinterpretation of cognitive tests. People have trouble performing certain tasks, but it's not because they have trouble, say, with their judgment or reasoning or memory. It's because they have trouble seeing things. So, for example, if you ask people to remember a bunch of pictures, they're not going to remember them very well because they haven't seen them very well, not because their memory is failing. And so we really think that the tests that will be used in clinical trials have to really be refined for PCA specifically. And it sounds like you and I should probably arrange a time to talk offline to think about ways that we can collaborate or
absolutely.
Think together. Yeah.
Absolutely. I love it. I've talked with Doug Galasco, who I know really well, and Brad Bovee about these things as well, and I'm sure you'll work with both of them. So yeah, we can talk offline anytime.
All right, very good. Thanks very much.
Hello.
Hi.
It was mentioned that this recording would be made available on the site, and I'm just wondering what site that is.
The PCA support site on Facebook.
The international one?
On both. On our site, that site I put up, which is called PCA Support, I could send you the link for that, and on the international one.
Okay, that would be great. Yeah, I think I must have missed the one about the US PCA Support Group. Sorry about that.
No, that's okay. Thank you. And it's important if to spread the word, because we want to get people, we want to create a US group that, so that we could have more research going, and so people know what centers, like Gil said, that people can go to that are closer to home for them.
Yes, posting that list of sites would be wonderful.
I will do that.
Thank you so much.
I will do that.
appreciate it. I'm looking forward to the next one.
Awesome. Thank you. Thank you, everyone. Have a wonderful day.
Okay. Thank you all.